refugees. So today's class will be on one of the important medical problem, very common in our practice. The most common arthropodal viral disease in the world and a big public health problem, that is dengue. So in the next few minutes, I would like to talk on introduction, epidemiology, etiopathogenesis, pathophysiology, clinical picture, diagnosis, and management of the different dengues and subsets. Finally, a few words on the prevention and the future directions. So the May 16th is the National Dengue Fever. So this is the slide shown by the government of the Odisha. The symptoms of the severe dengue, like any abdominal pain, bleedings, continuous vomitings, melena. So these are all how to admit in the hospital, not on a OPD basis. So these are the signs of the severe dengue. You have the few alternative names to the dengue. That is Onango-Nyang fever, West Nile fever, breakbone fever. So the breakbone fever because of the severe arthralgia associated with the dengue fevers. So this is the most common arboviral disease worldwide by the WHO, transmitted by the female mosquitoes of the genus Aedes. Both the subtropical and the tropical geographical distribution, nearly 150 countries in the world are involved with the dengue. And there are the 5 genetically different serotypes are available. Dengue virus 1 to 5. And there is about 50-fold increase in the global incidence over the last 5 decades. Every year the incidence is increasing. According to the WHO, 390 million dengue infections annually, of which 96 million manifest the clinical. You need to remember these figures, but most of the dengues, they are the asymptomatic. Nearly 75 to 80% of the dengues are the asymptomatic, and out of these symptomatic, nearly only 10 to 15% are posing the lot of the problems. But as it is endemic in nearly the 150 countries, and a lot of the people are exposed to this. Nearly the 5 billion people are exposed to the dengue, and you can imagine the number of the complicated dengue or the dengue hemorrhagic fever or septic shocks in our areas. Unfortunately, 75% of the global disease burden is in our Asia Pacific region, and mostly the Indians. And the actual number of the dengue cases are underreported or misclassified as the other viral diseases or other fevers. Mostly it is underreported. And India is having the highest number of the dengue cases in the world. The dengue virus was first isolated in India in 1945. Clinically dengue-like illness, it was not diagnosed as a dengue, but it is a clinically dengue-like illness occurred at Madras in 1780. And the first reported cases were from Vellore, Tamil Nadu, way back in 1956. And first hemorrhagic fever, dengue hemorrhagic fever outbreak was occurred in Calcutta in 1963. All 4 serotypes are found in Indian population. The 5th one is in Malaysia and Singapore. The area of the endemicity is increasing with about 450 million population at risk right now. At present, the dengue is endemic in 23 states of India. I think all the states in India are endemic right now. And the mortality rates here are 10 to 20%. Even 40% in the case of dengue shock syndromes. So this mortality rate increases from the place to the place. So when they are staying in the urban areas, the mortality may be a little lower when compared to the rural areas and the tribal areas. See the picture of the India. A lot of the outbreaks were there. Almost all parts of India, especially in the South India. So this is the global incidence, and see the red zone in the Indian subcontinent, nearly 7.5 to 32.5 million cases. And the cases and the deaths due to the dengue and fever are increasing like anything. Every year the cases are increasing, both the cases as well as the deaths. And the age wise, the highest proportion is in the 5 to 14 years of the age group. And between the 15 to 49 years or the 50 years, it is about 21.37%. The reasons for the change in the epidemiology, because of the increased epidemic activity, because of the increased endemicity, because of the increased number of the cases, because of the increased morbidity and the mortality. So these are the different reasons for this increase in the number. One important thing is increase in the air travel and improper water storage. Climatic change, more common in the rainy season and in the winter season. Uncontrolled population growth and rapid and unplanned urbanization. So these are all the important reasons for the increased proliferation of the vector and increased virus transmission causing the dengue. If you see the mosquito, the black and white body and also black and white wings, it's a mosquito-borne tropical disease caused by the dengue virus, and that one is the virus, is an enveloped virus, a single-stranded RNA virus. It's the single-stranded RNA virus. It's a flavivirus, a genus flavivirus. So this is the important vector is the Aedes aegypti that also causes the encephalitis, Zika virus, etc. Is a tropical and the subtropical species, relatively uncommon above the 1000 meters, may spend their lifetime in and around the houses. The lifetime of these Aedes aegypti is about 14 to 21 days. Immature stages are found in the water-filled habitats, larvae, pupae, etc. And sometimes not only the Aedes aegypti, maybe the Aedes albopictus and also the polynesiensis is also available to cause the dengue fevers. But mostly it is the aegypti, 95 to 99% of the cases. Sometimes maybe the albopictus. So as I told you, this is transmitted by the bite of the female Aedes mosquitoes, not the male. Male Aedes aegypti, they depend on the plant origin, plant food, whereas this is a non-vegetarian female. So they need human blood, and human blood contains a lot of the proteins. Those proteins present in the blood is needed for the female Aedes aegypti mosquitoes to lay the eggs, to form the eggs. So in India, the Aedes aegypti is the main vector in the most urban areas. Rarely other also available, albopictus or polynesiensis or nevius. Population and the lifespan. I told you the lifespan of these lifespan of these Aedes aegypti, maybe 14 days to the 21 days. That depends on the rainfall, the water storage, temperature, and the humidity, mostly in the rainy season. Survival best between the 16 degrees centigrade to the 30 degrees centigrade and a relatively humidity of 60 to 80%. So it is not possible to have these Aedes aegypti mostly in the summer region, because summer the temperature will be very, very high. So the peculiarities of these Aedes aegypti, to find a host, these mosquitoes are attracted to the chemical compounds emitted by the mammals. So these chemical compounds are ammonia, carbon dioxide, lactic acid, and octanol. Most commonly bite at dusk and dawn, indoors and in the shady areas. So breed in areas of the stagnant water. So you all know the places where it is a stagnant water, like flower vases, uncovered barrels, buckets, discarded tires. Okay, so these are the most dangerous areas, are the wet shower floors and the toilet tanks, as they allow the mosquitoes to breed in the residence. Research has shown that certain chemicals, especially the fatty acids associated with the bacteria involved in the degradation of organic matter in the water, stimulate the female mosquitoes to lay their eggs. It can transmit the infection transvirally also. So it has the 3 proteins and the 7 non-structural proteins. So the 3 proteins are the envelope protein, M protein, and the capsid protein. And the internal one is the single-stranded RNA, that is a genomic RNA. So this is the structure of the dengue virus. So you can appreciate here mostly the envelope protein, and then the membrane protein, and the internal one is the capsid protein, and a single stranded RNA that has the 3 structural proteins and about 7 non-structural proteins. So here the non-structural protein NS1 will be the positive in the initial days of the dengue fever. So out of the 7 non-structural proteins, you have the NS1 to NS5. NS2 and 4 are having the 2. So NS2A, 2B, and 4A, 4B, and NS1, 3 and 5 are the single. So out of them, so totally there were the 7 non-structural proteins, and the 3 structural proteins are the envelope protein, membrane protein, and the capsid protein. See, the most dangerous species is the dengue virus 2. Second serotype is the more dangerous, and the different serotypes available causing different epidemics in the Indian subcontinent. See, in the 64 Tamil Nadu, the prevalent serotype was the 2. In 68 Tamil Nadu, 1, 2, 3, 4, etc. So all the strains are available here, but the second strain or second serotype is more dangerous to lead to DHS and the DSS. So as I told you that this belongs to the virus flavivirus. The virus contains a single strand RNA. It's the very smallest in size. 5 serotypes. The antigens can cross-react with other members in the same genus. Infection with any one serotype confers the lifelong immunity to the virus serotype. That is a very important point to be taken out. So the one serotype infection will have a lifelong immunity. So maximum the people will have the 5 types, 5 attacks of the dengue fever caused by the 5 different serotypes. But out of them, the second serotype is more dangerous. See, last one, then dengue viral infection, the patients have the measurable levels of the NS1 protein in the blood, a diagnostic marker of the infection. But this NS1 will stay in the blood for maximum 7 days to 8 days only. So in the second week, usually the NS1 will be the negative. So that is the reason when the fellow's fever is of 10 days or the 15 days duration, and if you test the blood for the NS1, it will be the negative, because it will be positive only in the initial first 7 to 8 days only. After 7 to 8 days, the NS1 will be the negative, and then you will have the M positive and also the G positive. See, the female Aedes feeds on the blood. This is because they need the protein found in the blood to produce the eggs. So the male mosquitoes feed only on the plant nectar. On average, female Aedes mosquito can lay about the 300 eggs during her lifespan of 14 to 21 days. This is the life cycle. See, this live for about 14 to 21 days and about the 300 eggs. And these eggs will become the larvae and the pupae, and finally again an adult Aedes mosquito. So lifespan is maximum. See, the eggs to become the larvae, it will take 2 to 3 days, and larvae to pupae, it will take another 4 to 5 days, and the pupae will become the adult Aedes mosquito in 1 to 2 days period. So maximum 7 days to 10 days. So the bites on the infected person, and then infected moji bites a healthy person, and then the healthy person comes down with the dengue fever, and again that's how the life cycle goes on. So the Aedes aegypti is a very dangerous one, not only causing the dengue, that also causes the Zika and also chikungunya. So the Zika, dengue and chikungunya are caused by the Aedes aegypti. So this is a very beautiful slide, shows you the differences between the Zika, dengue and chikungunya. If you see the fever, that will be positive in all the 3 things. So in all the viral fevers, whether caused by the Zika virus or dengue or the chikungunya, so that will be the positive. Rash will be positive more in Zika and also in the chikungunya, but less in dengue when compared to the Zika and chikungunya. Conjunctivitis, Zika virus more. Arthralgias, chikungunya very high. So you all know the chikungunya arthralgia is very difficult to walk, very difficult to sit down, and it's very difficult. So maximum arthralgia will be there in chikungunya. Myalgias more in the dengue fever. Headache, dengue, mostly the retroorbital headaches, retroorbital pains. Chikungunya also will have the headaches. Hemorrhage, again in the dengue, maybe the capillary leakage or maybe the hemorrhages in all the forms, maybe the petechiae or purpura or ecchymosis or any epistaxis, hematemesis, melanochezia, melena, etc. So these are very common hemorrhagic in dengue fevers. And the shock, again more in the dengue. So this is how we have to differentiate between the Zika, dengue, and the chikungunya. So fever, rash, conjunctivitis, arthralgia, myalgia, headache, hemorrhage, and the shock. All three are caused by the Aedes aegypti. So the dengue depends on the three factors. One is the agent, that is here the agent is the virus and environment, and the host is the man and the mosquito. So the dengue virus infects the humans and the several species of the lower primates. People of all ages, mostly the young people between the 10 to 15 years of the age group, and also the 15 to 40 years of the age group are also involved here. More in less than the 15 years of the age groups and in the females. Secondary dengue infection is at risk for the dengue hemorrhagic fever, including the possibly acquired antibodies in the infants. Travel to dengue endemic areas is the most important risk factor. So history of the endemicity or history of the recent travel to the endemic areas. So this is a very important clinical point to clinch the fellow is having the dengue. Migration of a patient during an viremia to a non-endemic area may introduce the dengue into that area. The geographical spread of the dengue has been reported to occur mainly by people traveling from endemic areas to the non-endemic areas. Now only few places are non-endemic: US, Europe, and Australia. Almost all other places are very much endemic for the dengue. If you see the pathophysiology of the dengue viral infections, the production of the antibodies and presence of the enhancing antibodies. You will have the IgM antibodies and IgG antibodies, and the M antibodies will start from the third or the fourth day, whereas the G antibodies will start in the second week. Antigen antibody reaction with the complement activation, deposition on the vessels, various tissues, and the platelets. So there will be the capillary impermeability, and there will be the capillary leakage, and then more and more fluid enters into the third space, especially your ascites and pleural effusions. So these are all very common because of the capillary leakage. So clinical manifestations of the coagulopathy, bleeding. So you all know how the bleeding gums, epistaxis, ecchymosis, these are all very common. So finally the people will end into the hypotension and the shock with the pleural effusion, ascites, bleeding, organ involvement. So this is a very severe stage. So here we have to admit the patients in the ICU and then treat accordingly. And the dengue virus, there will be the activation of the T cells, the production of the various chemical mediators. So increased vascular permeability and the clinical manifestations of the vasculopathy, this is a capillary leakage. So one hand you will have the capillary leakage, on the other hand you will have the bleeding tendencies. So these two will lead to the hypovolemia, dehydration, etc. So it's a complex disease with interactions among the virus, vector, and the host. You know these virus, you know the host and the mosquitoes. The transmission is both the endemic and epidemic in many countries, especially in our Indian population. So there will be the increased probability of the dengue hemorrhagic fever because of the hyperendemicity. So there will be increased circulation of the viruses, increased probability of the occurrence of the virulent strains, increased probability of the secondary infection, and increased probability of the immune enhancement. So there will be the more and more chances of the dengue hemorrhagic fever because of these two reasons. Again, your bleeding tendencies and your leakage. See the step one here, there will be the homologous antibodies. They form the non-infectious complexes. And if you see here, that is a virus, dengue 1 virus, and neutralizing antibody to the dengue, and virus non-neutralizing antibodies, and the complex is formed by the neutralizing antibody and the viruses. So once there is an antigens and the antibody formations, there will be the antigen antibody complexes will form, and finally it depends on the body immunity, and the fellow is having the good immunity, so they don't involve with any symptoms. Otherwise most of these people will fall into the symptomatic dengue, otherwise asymptomatic. Here the heterologous antibodies of the first serotype infection form the infectious complexes with the second serotype, the dengue 2 virus. So here it is a complex enter more and more monocytes and the macrophages, where virus the replicates. Now the virus replication involving almost all the cells, and finally it is the hemorrhagic fevers. So the affected macrophages, your monocytes or lymphocytes, etc., they release mediators, vasoactive mediators that increase the vascular permeability, leading to the vascular leakage, hypovolemia, and the shock. Infants born to the mothers who have had dengue as maternally derived dengue neutralizing IgGs vein are also thought to be at risk of enhanced disease. So in initial days, the infants born to the mothers will have the IgG antibodies. So they are the protective. But as the days goes on, again they are at high risk of getting the infections. So the activation of the classic complement pathway and the cross reactive of the T cells, so that leads to the lot of permeability and the bleeding tendencies. So the vasculopathy, thrombopathy, coagulopathy, and bone marrow depression. So these are the very important features in dengue shock syndromes and the dengue hemorrhagic fevers. So you will have the vasculopathy, and you will have the thrombopathy with the impaired platelet function and moderate and severe thrombocytopenia, and coagulopathy with the activation of the coagulation and the fibrinolysis, and in the latter stages the DIC, and bone marrow depression, the reduced megakaryocyte production. So this suppressed megakaryocytopoiesis and increased platelet clearance by the dengue virus induced apoptosis and the antiplatelet antibodies. So what are the factors responsible for the complicated dengue? So the presence of the enhancing and non-neutralizing antibodies. A's, females, race, malnutrition. Malnutrition here is the protective, so the nutritional status. Sequence of the infection, serotype 1 followed by the serotype 2 is more dangerous than the serotype 4 followed by the serotype 2. So this is the very important thing. So 1 followed by 2 is more dangerous. Okay? Infecting the serotype, type 2 are more dangerous than the others. And infecting the genotype, Asian type 2 causes dengue hemorrhagic fever and shock syndrome, while the American type is not responsible for the illness. So the Indian dengue viruses are very, very dangerous, causing lot of the hypotension and the shock syndromes. See, this is the dengue infection. These are all the clinical syndromes. So some people, they present with the fever. So high grade fever, fever associated with the headache, retro-orbital pain, myalgia, arthralgia, that is your breakbone fevers, and you should suspect a suspected dengue. But some people will have the positive tourniquet test, so that is a test for your things. So when the fellow's blood pressure is between 120 by 80, so midway at about 100, you can have to inflate the cup for about the 5 minutes, and then if you see there will be the more than the 20 petechial hemorrhages in about 1 square meter of the surface area. So that is your positive tourniquet test. So that is also positive in most of the dengue fevers. And increased vascular permeability, so that is your plasma leakage. So the more and more fluid into the third spaces, so the people will have the pleural effusion, will have the ascites. So very commonly if you see an X-ray in a dengue fever, so people will have bilateral pleural effusion. And if you subject them for ultrasound abdomen, so there will be the ascites. Okay, so the ascites and pleural effusions are very common here. And hepatomegaly, and then thrombocytopenia. So thrombocytopenia can be divided into 3: the mild thrombocytopenia, moderate, and the severe. Mild is platelet count between 1 to 1.5 lakhs. Moderate is 50 to 1,000, 1 lakh, and severe is less than the 50,000. So in dengue fevers, you need not go for the transfusions till the platelet count is less than the 10,000. or even if they are more than the 10,000, even at 15,000, 20,000, when the fellow is presented with the shock syndromes or in the severe coagulopathy, then you can advise the platelet transfusions. Otherwise, platelet transfusion is not the only answer in the treatment of the dengue fever. So this is the very good slide, shows you dengue without warning signs and with warning signs. Okay. So the criteria, what are the probable dengue? The probable dengue, as I told you, history of the travel to the dengue endemic areas, or living in a country where it's very endemic like our Indian place, the fever and two of the following criteria. So the people will have the fever, that is an acute fever, maybe fever with the chills and rigors, plus nausea, vomiting, rash, myalgias, tourniquet test positive, leukopenia, and any warning signs. So the leukopenia occurs first when compared to the thrombocytopenia. So in all the dengue probable fevers, in the early days of the dengue fever, you concentrate on the total WBC count rather than the platelet count. So the initial count to be reduced is the total count, that is the leukopenia, and then the thrombocytopenia starts. And dengue with the warning signs. So this is, see, the dengue without warning signs or the probable dengue can be treated outpatient. Okay, because his BP is okay, there is no fluid leakage, there is no shock, and everything is fine. So you can treat it with the outpatient with some paracetamol, etc. Whereas this warning signs, dengue is very dangerous. So as a physician, you should suspect the dengue with the warning signs and keep them admitted under your observation. Otherwise, some of these people will enter into the dengue hemorrhagic fever and dengue shock syndromes, and then the mortality will be very high. So what are the warning signs in the dengue? So abdominal pain and the tenderness, persistent vomitings, okay, fluid accumulation in the third space, mucosal bleed, so severe lethargy, restlessness, hepatomegaly more than 2 centimeters, and increase in the hematocrit. So increase in the hematocrit shows the leakage of the plasma leakage into the third space. So once the plasma leakage into the third space, so there will be more and more RBC accumulation in the blood, so that leads to your increased HCT. So increased HCT means increased PCV, packet cell value, so that shows the fellow is in severe dehydration. So you have to give more and more fluids. So once the HCT is coming to the normal, that means the fellow is progressing. Good health. Once the HCT is very drastically reduced, that shows the signs of your bleeding. So in the bleeding, the RBCs will escape from the blood. So definitely more and more plasma there. So that is the reason HCT will be the lower. Then you have to give the colloid solutions like albumin or the blood transfusions or the RBC transfusions. So when the HCT is more, that shows you the plasma leakage. When the HCT is very, very low, that shows you the bleeding tendencies. And here when the HCT is more, you can give the normal saline. When the HCT is very, very low, you can give the blood transfusions, either RBC transfusions or the whole blood transfusions. And then the criteria for the severe dengue, here the severe plasma leakage, the fellow is in the shock, so there will be the systolic blood pressure will be less than the 90, very short pulse pressure, and fluid accumulation with the respiratory distress, and severe bleeding, maybe the hematochezia or hemoptysis or epistaxis or ecchymosis or petechiae, purpura. So these are all very common in the bleedings. So you know by this time what you mean by the petechiae, what you mean by the purpura. Petechiae means less than the 3 mm size. Blood spots, red spots less than 3 mm is petechiae. Between 3 mm to 1 centimeter, that is the purpura. More than the 1 centimeter, that is the ecchymosis. Okay. Severe organ involvement in the liver, there will be the hepatomegaly more than the 2 centimeters, and your SGPT, SGOT will be very much elevated, and the patient is CNS impaired consciousness, and then heart and other organs, there may be the myocarditis. Some people will lose in dengue fevers because of the viral myocarditis. So the clinical course of the illness passes through the 3 phases. One is the febrile phase, and the second one is the critical phase, and the third one is the recovery phase or the convalescent phase. So you are all familiar with the febrile phase. That is not that dangerous, but the most important phase is the critical phase. So the critical phase starts after 4th day or the 5th day of the fever. Here in the critical phase, the patient is febrile. So the patient or his relatives are worried about the febrile phase, temperature. So once the temperature comes to the normal, they want admission, discharge from the hospitals. So after the febrile phase, the critical phase starts. So this is very difficult to answer them or to convince them for the more and more hospital stay. But because this critical phase is very dangerous one, if left untreated, and definitely the people will have more and more mortality. So clinical diagnosis, the things to consider: exposure history, so endemic or travel, consistent with the dengue like other disease exposures or acute febrile illnesses, and clinical laboratory findings consistent with the dengue at this juncture. So the people may have the leukopenia or NS1 antigen positivity. So here incubation period is 4 to 10 days, usually 4 to 7 days. So after the bite, the people will get the fever on the 3rd day or the 4th day. So that is the incubation period. Okay. Sudden onset of the high fever, high grade fever. So this is the good start. Show you the febrile phase and the critical phase and the recovery phase. See here, see the temperature. It is a very high in the febrile phase. Potential clinical issues, mostly the dehydration. Laboratory changes, usually the normal, maybe leukopenia, not the thrombocytopenia at this juncture. And serology and virology, usually they will have NS1 antigen positivity. And if you get the PCR, that may be the positive. And the ELISA test, usually that may be the negative. And phases of the illness, this is the febrile period. So this is a very important phase. Here the treatment is mostly paracetamol and reassurance, because 80 to 90% of these cases will cut down to the normalcy only. Only 15 to 20% of these people, dengue, will enter into the critical and the recovery phase. So the febrile phase usually lasts for the 2 to 7 days. A progression to the recognize the progression to the critical phase. That is the beauty of our physicians. Okay, you should recognize the this period, the people progression to the critical phase. Mild hemorrhagic manifestations like petechiae and mucosal bleeding may be seen here. So the earliest abnormality is not the platelet reduction, but it is the leukopenia. What are the signs and the symptoms at this here? So all the features of your fever, your headache, retro-orbital pain, myalgia, arthralgias, anorexia, nausea and vomiting, diarrhea. So these are the rashes. So they are very common. And investigations, as I told you, the leukopenia with or without thrombocytopenia, a positive tourniquet test, NS1 antigen positivity, and dengue IgM antibody test is an optional, maybe positive when the fellow comes on the 4th day or 5th day of the fever, because it will take 3 to 4 days to appear, IgM antibody appear in our body. So most of our people, they don't come on the first day to the physician. Usually by the time they come to the physician, already 5th day or the 6th day or the 7th day of the fever. So usually IgM also will be the positive along with your NS1 antigen positivity. Here the complications, the dehydration. So the treatment is rehydration and paracetamol. So next the critical. This is the first 3 days is the febrile, and then the critical period starts on the 4th, 5th and the 6th. Sometimes maybe the 7th day. So 4 days is the critical period. So here the temperature is normal. So the people, they don't have any temperature there, but here more and more dehydration, more shock, bleeds. Okay, laboratory investigations. So more further leukopenia, and then further thrombocytopenia. And here maybe the IgM positivity or NS1 positivity or your PCR positivity or your ELISA positivity will be here. So this is the biphasic lasting 5 to 8 days febrile. Common lesson is the headache, flushing and the rash. There will be the pain in the retro-orbital area, muscles, joints or the bones. Rash may be maculopapular or rubiliform like measles rash. Usually appear after 3 or 4 days of the fever and commonly seen in the face, neck and other parts of the body, maybe in the anterior chest and the posterior chest, maybe on the thighs, on the legs, etc., and fades away in the latter part of the febrile illness. This is a blanching rash here. So that the specialty of the dengue rash is blanching rash. Okay, localized cluster of the petechiae may appear over the upper and the lower limbs also. So during the first 1 to 2 days of the fever, the children may develop a transient generalized erythematous rash which blanches upon the pressure. The rash of dengue appear about 2 to 3 days after the deference. It is called as white islands in a sea of the red. So that is a appropriate word we use for the rash in the dengue fever. White islands in a sea of the red. So this is the critical phase. Critical phase after 3 to 4 days of the onset of the fever. During this phase, there will be the more and more plasma leakage and high hemo concentration. So your HCT will be elevated here. They are documented, and patients may develop the hypotension because of the plasma leakage. Abnormal hemostasis and the leakage of the plasma leads to the shock, bleeding, accumulation of the fluid in the pleural and the abdominal cavity, and the people will have the dyspnea, will abdominal tenderness, or abdominal pain, distension, nausea, vomiting. So they all will occur here. High morbidity and the mortality are commonly associated with the various organ involvements and metabolic derangements. So here you will have the hepatomegaly, and you will have the gastrointestinal involvement, you will have the respiratory involvement, you will have the cardiac involvement, and sometimes maybe the acute kidney injury is also a possibility here. So because of these, so these people will have a metabolic encephalopathy also. The period of plasma leakage usually persists for about 36 to 48 hours. So this is the critical phase. So again, you see the temperature, see the potential clinical issues like shock, bleeding, etc. In the laboratory, I already told you. Okay, leukopenia and thrombocytopenia. And the serology, NS1 positive and IgM positive. IgG will not be positive in the critical period. See, it is the day 3 of the 7 of the illness when temperature drops to the normal or less and remains below this level. Patient can either improve or they deteriorate. So the improve dengue without the warning signs, and deteriorate dengue with the warning signs and the severe dengue. So you have to concentrate on the vitals. So when the fellow is having the tachycardia, tachypnea, orthopnea, PND, etc. So that means more and more accumulation. So you have to, this fellow is deteriorating. Otherwise, when the appetite is good, he is afebrile, he is not having myalgia, he is not having arthralgia. So the vitals are very, very normal. So that means the fellow is very much improving. So the warning signs here, the abdominal pain, already told you, warning, abdominal pain, tenderness, vomitings, bleeding, fluid accumulation, lethargy, liver enlargement, and laboratory. Here the platelet count will be moderate, less than the 1 lakh. And sometimes maybe the less than the 50,000 is a possibility here. But don't start giving the platelets when the platelet count is 50,000 or 1 lakh or 1.5 lakhs. Okay. You wait till the 10,000s or the 20,000s are with the bleeding tendencies. Then only there is an indication for the platelet transfusion. But simple number is not sufficient for the transfusions. This is the good slide, shows you the compensated shock or hypotensive shock and the stable circulation. See, in the hypotensive shock, the stable circulation, you will have the clear and the lucid. In a compensated shock, the clear and lucid shock can be missed if you do not touch the patient. So the volume of the pulse is very, very important. See the volume of the pulse. Okay. So the change of the mental state, restlessness, these are all very common in hypotensive shocks. Capillary refill time, brisk within less than the 2 seconds. So very stable. If it is more than the 2 seconds, capillary filling time, that means the patient is in shock, decompensated shock or hypotensive shock. Extremities, they are the warm and the pink extremities are good, but cool peripheries, cold and calm extremities, so more of shocky feature. Peripheral pulse volume is a good volume, is the stable, whereas the weak and feeble or the absent, so that is definitely a shock. Heart rate, very high heart rate in the shock period. Blood pressure, narrowed pulse pressure, less than the 20 mm, and the low systolic, maybe systolic less than the 90, Respiratory rate, very tachypnea, sometimes metabolic acidosis, push malls respiration. So these are very common. So when you are dealing a case of the dengue, when you are thinking of any dengue hemorrhagic shocks or the shock syndromes, so you have to concentrate on the pulse, blood pressure, not only the systolic but also the diastolic, and the pulse pressure, and then the volume of the pulse. So these are very important to assess whether the fellow is in the shock or not. So these are the stages of the shock: initial, compensated, hypotensive or decompensated, and refractory, and finally left untreated death. So as a physician, we should concentrate on these hypotension and the refractory shocks. So you can do a lot here. Otherwise, if you miss these conditions, the patient will definitely going to die. Even today, we are seeing a lot of the deaths in the dengue. So the dengue fever is a very, very big problem in our society. So this is the recovery phase where the temperature no, potential clinical issues no, because good rehydration, laboratory changes, the platelets are going up. So after coming to the 30,000 or 40,000, now the rising in the platelets will be seen, rising in the total count will be seen, and there will be the appearance of the IgG also, antibodies also appear at this juncture. So these are all the features of the recovery, and finally he will be happy. So in the recovery phase, gradual reabsorption of the extravascular fluid from the intravascular to the extravascular space. So no more leakage, and improvement of the well-being. So no abdominal tenderness, no abdominal pain, no nausea, no vomiting, good appetite. So no lethargy, no headaches. So these are the stable hemodynamical stats, and there will be good diuresis. And appearance of the classical rash, WBC rises soon after the recovery phase. Then the platelet count also will become the normalizations. Here the complications, hypervolemia. So if you don't understand that the patient is in the recovery phase and you keep on giving the IV fluids, so then the people will have hypervolemia. Okay, so sometimes we lose the patient because of the pulmonary edemas, or maybe because of the acute kidney injury if you don't respect the urine output. So this is again, as a good clinician, you should see that the fellow is in the recovery phase and don't give much of IV fluids. Otherwise, the people will go into respiratory failure or pulmonary edema. See the final last one. The patient may develop pulmonary edema due to fluid overload if the fluid replacement is not optimized carefully. So these are all the clinical manifestations, almost all. In the brain, you will have the headache, fever, bleeding gums, nose, eyes, vascular symptoms. You have the leukopenia, thrombocytopenia, neutropenia, late eosinophilia, and reduced coagulation. Skin, you will have the rash, bruising, petechiae, purpura, ecchymosis, joint pains, arthralgias, altered hematopoiesis, and vascular hypovolemia, low blood pressure, shock. Liver, you will have the hepatic injury, fluid pooling in the body cavities, ascites and pleural effusion. Maybe gallbladder thickening, the wall thickening, hemorrhagic within the organs, and the vomiting, intestinal bleeding, and infrequent complications like encephalitis, acute pancreatitis, renal failure, myocarditis, splenic rupture, pulmonary hemorrhage. So these points as a physician we should remember. So normal, everyone knows that, but sometimes there will be infrequent complications, like the people presents like encephalitis, acute pancreatitis, okay, acute kidney injury, myocarditis, splenic rupture, and pulmonary hemorrhage. So clinical evaluation in the dengue fever. So you have to record the blood pressure to know the systolic, diastolic, and also the pulse pressures. Evidence of bleeding in the skin and other sites, like your positive tourniquet test, or about the amount of the number of the petechiae, etc. Hydration status, so skin turgority or sunken eyeballs, etc. Evidence of increased vascular permeability, so the plasma leakage into the third spaces, like pleural effusion, so your dull note at the bases, or that sounds not heard properly, and then the ascites. So these are all very important clinical evaluations in the dengue fevers. So this already told you how to do a tourniquet test. Take the patient's blood pressure and record it. For example, it's 100/70. Take the midway between the systolic and the diastolic and inflate the cup for about 5 minutes and reduce and wait for 2 minutes. Count the petechiae below the antecubital fossa and positive test 10 to 20 or more petechiae for square inch of the surface area. So here the WHO revised classification divides it into 3 groups. Dengue. Dengue without warning signs, that means simple fever. Dengue with warning signs, that already told you the abdominal pain, etc. And severe dengue, that is our shock syndromes. So this is the good slide, shows you how you deal the dengue fevers. So when the dengue viral infection, symptomatic and asymptomatic. So 80% are asymptomatic, maybe 20 are the symptomatic. So among the symptomatic, you divide into mild dengue, moderate dengue, and the severe dengue. Okay. So the mild dengue, again the OP basis, and the full recovery is guaranteed in mild dengue. So they are undifferentiated dengue or fever without any complications and without any evidence of the capillary leakage. So home management with only hydration and paracetamol. But we are much worried about these two things, moderate dengue and the severe dengue as a physician point of view. So the moderate dengue, here again it's divided into 2 groups. So dengue fever with high risk and comorbid conditions like diabetes or CKD or IHD or CVA. So these are all. And dengue fever with warning signs and the symptoms. Okay. See, dengue fever with high risk and comorbid conditions. Who are at high risk under the comorbid conditions? Infants, old age, elderly, diabetes, hypertension, pregnancy, coronary artery disease, hemoglobinopathies, immunocompromised population, patients on steroids, anticoagulants, or immunosuppressants. So we see all these people except the infants. We see all other groups of the patients. So these are very, very carefully we have to choose for the dengue fevers. So should not think that these population is a very dangerous one, especially elderly individuals. Diabetes, hypertension, pregnancy, and dengue is a big problem. Coronary artery disease, hemoglobinopathies, immunocompromised population. And a lot of the people are on the steroids and immunosuppressive drugs, like a known autoimmune diseases. So these people have to admit them and then close monitoring. And then dengue with warning signs and the symptoms. So already I told you them. So they are the recurrent vomitings, abdominal pain, generalized weakness, restlessness, pleural effusion, ascites, hepatomegaly, and then HCT, hematocrit elevation by 20%. So that is plasma leakage. So again here, a close monitoring and possibly hospitalization. I always prefer hospitalization at this juncture, provided if the patient is not within your place. Then what about the severe dengue? So definitely they need admission, not only in the wards, maybe in the ICUs also. So they are with a significant hemorrhage, with shock, with severe organ involvement, and then the metabolic disorders like your metabolic acidosis, etc. So they need intensive care and your intensivist approach. So this is the probable dengue. Already I told you these things. Signs with and without warning symptoms. Severe dengue. Mimics of the dengue fever. So not all the fevers are the dengue. Okay. So the flu-like syndromes. Maybe simple influenza, common cold, measles, chikungunya, because chikungunya, Zika virus, and dengue are caused by the Aedes aegypti. Infectious mononucleosis, HIV seroconversion illnesses. So usually we have the influenza and sometimes chikungunya. Now chikungunya is not that common, but commonly the flu-like syndromes when the fellow is present with the fever, a common DD for your dengue is a simple cold. Now the illness with the rash. When the fellow is presenting with a rash, what are the reasons? So it could be rubella, a measles rash, a scarlet fever, meningococcal infections, chikungunya, and then the drug reactions or a Zika virus. Okay. Diarrhea, fever with diarrhea, maybe the rotavirus and other enteric infections. Fever with neurological manifestations like meningitis or encephalitis or meningoencephalitis, etc. So these are all the mimics of the dengue fever. When the fellow presents the fever with a rash, with the diarrhea, or with neurological illnesses. When you fellow with the presence of the infections, different infections like acute gastroenteritis or malaria, leptospira, typhoid, typhus, viral hepatitis, HIV, bacterial sepsis, or the septic shock. So the dengue with infections. So these are all the different DDs. Okay. Malignancies, acute leukemia, other malignancies. They also present like severe bony pains. So sometimes acute leukemia they present like arthralgia only. Other clinical pictures: acute abdomen, acute appendicitis, acute cholecystitis, etc. So all these can be DD. By seeing our peripheral picture, we can rule out many causes. By seeing your ultrasound abdomen, we can rule out many diseases. By seeing your X-ray, we can rule out many DDs. In the same way, when the LFT, RFT, etc. So in all these fevers, acute fevers, you should have a complete blood picture, liver profiles, renal profiles, ultrasound abdomen, chest X-ray. So with them, all these DDs can be ruled out. And then finally, your diagnosis will be only one. When you are thinking of the dengue, get the NS1. So workup of a patient with the dengue. So the laboratory diagnosis, virus isolation, genome detection, antigen detection, and serological diagnosis. Some supportive investigations like your liver function tests, etc. Virus isolation is the cultured mosquito cells and mammalian cells used the gold standard, but low sensitivity and long detection time. Genome detection, your PT, RT-PCR. Antigen detection, your E and M antigens and NS1 antigens. So this is the most important and most rapidly detected test here. And ELISA is also possible, IgM and IgG antibody detection. So this is the good one. Shows the approximate timeline of primary and secondary dengue infections and diagnostic methods that can be used to detect the infection. Okay. See the onset of the symptoms. You will have the NS1 detection on the top. NS1 detection. So that will be there from 0 to maybe 4th or the 5 or 6 days or 7, maximum at the 7 or 8 days. And virus isolation, your RNA detection or RT-PCR. So that can be the possible, but usually we don't get it done. And your IgM and IgM antibodies. Okay, primary and the secondary. And IgG primary and IgG secondary. So interpretation, highly suggestive, one of the following: IgM in a single serum sample, IgG in a single serum sample with a HI titer of 1280 or the greater. Confirmed PCR positivity, virus culture. Here you can remember the IgM only, okay? And PCR virus culture is only for that. So this is the good slide. So rough guide for the interpretation of the dengue serology reports. See IgM negative, IgG negative. What is your impression? No dengue or most earliest sample. Okay. The first thing is not dengue because both are the negative here. IgM negative, IgG positive. IgG positive means already had exposure to the dengue. So the past dengue infection, not the present dengue. Past dengue will have the IgG. IgG will stay for many days, maybe few months also. IgM negative, IgG positive in very high titers. That is secondary dengue infection. Okay. IgM positive, IgG negative, M positive, G negative. That is your primary dengue infections. Okay. IgM positive, IgG is also positive, low titer. So that means recent primary dengue infection. Already had another dengue earlier. So that is the reason IgG was positive. But now the IgM is also positive. Okay. So this is how we have to see that. So positive, positive, negative, negative, positive. So any doubt in this slide? So when the both are the negative, so no dengue. No dengue. When the IgM is positive, that is means a primary dengue infection. When the IgG is positive, that is a secondary dengue infections. When they both are the positive, mostly the recent primary or the recent secondary. See, NS1 antigen detectable from the day 1 till day 18, but usually day 7 and 8, but about 80 to 90% of the cases. It may not stay beyond the 10 days. IgM antibodies, day 5 up to day 90. IgM, that is your acute infections, or primary dengue. IgG, day 18, that is the first flaviviral infection. From the day 1, if it is a second one, second serotype. So 2 years also. So last year infected with the dengue, now you can get the IgG positivity. So after next month, if he has also IgM positivity, that means a secondary dengue infection. So other laboratory tests, the liver enzymes, the creatinine, cardiac enzymes, etc. There are supportive investigations. So very important is the complete blood picture, metabolic panel, provided the patient is a diabetic and elderly or CKD or CAD. Serum proteins and albumin levels, so hypoalbuminemia, liver panel, Dick panel, X-ray effusions, ultrasound abdomen ascites. So these are the very important investigations. Characteristic findings in the dengue fever. So thrombocytopenia, leukopenia, mild to moderate elevation of the aspartate aminotransferase, SGPT or SGOTs, maybe elevated here, maybe 200, 500, 600. In patients with the dengue hemorrhagic fever, increased hematocrit level secondary to the plasma leakage or the third space fluid loss, hypoproteinemia, prolonged prothrombin time, prolonged APTT, and decreased fibrinogen, increased amount of the fibrin split products. What are the markers for the severe dengue? Increased urinary levels of the heparan sulfate, increased plasma levels of pentraxin 3, decreased serum albumin, so your hypoalbuminemia, increased levels of the VEGF, so vascular endothelial growth factors, and increased levels of VCAM, that is vascular cell adhesion molecules. So as a postgraduates, we should know these things. So the markers of the severe dengue. So your hypoalbuminemia, VEGF or VCAM, etc. So these are the atypical manifestations. So these are also very common. So as a physician, we should pay much more attention on these atypical manifestations. So CNS involvement, it could be encephalopathy, encephalitis, febrile seizures or intracerebral bleed also. Okay. GI, maybe acute hepatitis, fulminant hepatitis, cholecystitis, cholangitis, and acute pancreatitis. So they're all because of the dengue. Renal involvement, acute kidney injury, hemolytic uremic syndromes, or ATN, acute tubular necrosis. So these are the renal involvement in dengue fever, atypical manifestation. Cardiac, myocarditis is very common, arrhythmias, cardiomyopathy, and pericardial effusions. Respiratory is very common, ARDS is very common in dengue, pulmonary hemorrhages, pleural effusions, and pulmonary edema. Okay. Eye, conjunctival bleed, macular hemorrhage, visual impairment, or optic neuritis. What are the differential diagnoses? Dengue-like diseases like chikungunya, Rift Valley fever, Rose River fever, so these are all without the rash with lesions. Early stages of the malaria, so they are also acute fever. sudden rise of the fever with arthralgia, etc. Yellow fever, viral hepatitis, leptospirosis, and viral respiratory and influenza like diseases. So how to manage? Treatment of uncompleted dengue fever is supportive only. Bed rest is advised during the febrile period. Antibiotics, mostly the paracetamol. Don't give the brufen or the diclofenac here. Maybe chances of gastrointestinal hemorrhage. So analgesics or mild sedation may be required to control the pains. Aspirin is contraindicated. Fluid and electrolyte replacement required for deficits caused by the sweating, fasting, thirsting, vomiting, and diarrhea. Usually the oral only, not the IV is also not required here. So the only bed rest, paracetamol, and hydration. Encourage plenty of oral fluids, fruit juices, other fluids containing the electrolytes and the sugar. Give paracetamol for eye fever if the patient is not comfortable. Inform the patient about the warning signs. So then he should be get admitted. Otherwise, if there is no warning signs, need not be admitted here. So what are the indications for the hospitalization? Suspect the severe dengue and the need for the hospitalization when the patient develops giddiness, cooler extremities compared to the trunk and extremities, oliguria with a dark urine, so that means acute kidney injury, here the shock, right hypochondrial pain or severe abdominal pain, so that means hepatitis and elevated SGOT, SGPT, hepatomegaly, maybe cholecystitis, maybe pancreatitis, etc. Bleeding from any side because of the severe thrombocytopenia, persistent vomitings, lethargy, irritability, and restlessness. So that is maybe your encephalitis or encephalopathy like picture. So these are the symptoms, warning symptoms for the hospitalization. What are the management priorities of a patient with severe dengue? One, the replacement of the plasma losses, recognition of the management of the hemorrhage, prevention of the management of the fluid overload, prevention of the iatrogenic infections. Okay, so the replacement of plasma losses by giving your fluids, crystalloid fluids. Okay, recognition of the management of the hemorrhage by noting your hematocrit values. So sudden fall in the hematocrit levels. So give the RBC transfusion or whole blood transfusion. Prevention and management of the fluid overload. Okay, stop giving the IV fluids. If the systolic blood pressure is good, you can give the diuretics also. So that is how you have to reduce the fluid overload. Then prevention of the iatrogenic infections. So it's a very common. So when the iatrogenic infections are there, definitely you have to suspect them and then send the blood for the culture and sensitivity, etc. Urine culture and sensitivity and appropriate antibiotics. So these are very, very important here. Initial inpatient management, establish the IVSS, collect the samples for the blood group, hemoglobin, PCV, and the platelets. So these are the very important. PCV and the platelets are very important. Okay. Monitor the pulse volume, blood pressure, abdominal girth, so to rule out any ascites, and urine output to rule out acute kidney injury. So crystalloids and the colloids. So what you mean by the crystalloid and the colloid? So in the crystalloid, when you give the blood fluids into the vessel, there may be leaking from the vessel or permeability from the vessel to enter into the third interstitium and into the cell. Whereas when you are giving the colloids, say they don't come out of the vessel wall into the interstitial space. So that is the colloid and the crystalloid. So in giving the IV fluids, we have the three things. One is the cell, the second one is the interstitium, and then the vessel. So when you are giving the fluid into the vessel, so the fluid may leak into the interstitium. So that is the crystalloids. Whereas when you are giving the colloids, colloids means your albumin, dextran, etc. are the colloids. So they don't leak from the vessel wall into the interstitium. And then the blood pressure will go up and the people will comfortable with the colloid therapy. Okay. So the colloids, you have to use it when the fellow is in deep hypotension, in severe hypotension. So the colloids provide volume expansion over and above the actual fluid volume infused. Crystalloids have no added volume effect. Major concerns with the use of colloids are impact on the coagulation and the allergic reaction. Hence, crystalloids are ideal for the initial resuscitation, and colloids better serve in severe shock with undetectable blood pressure. So, your choice, normal saline or ringer lactate. Okay. So, the ringer lactate contains the potassium, it contains the lactate. So, there are high chances of having the lactic acidosis and hyperkalemia, etc. And provided if you don't check the electrolytes. So, preferably NS preferred over the RL due to the risk of worsening the tissue acidosis and lactate accumulation when large volumes of the RL is infused repeatedly. So, one hand you are thinking of about metabolic acidosis here. So, by giving more and more lactate, so you can give a more chances of having the lactic acidosis. So, in such situations, when the dengue hemorrhagic fever and the dengue shock syndrome, the fluid of choice is your normal saline, like your DKA. So, diabetic ketoacidosis, we give only normal saline. Again, here in the dengue also, we give normal saline only. So, large volumes, 0.9% saline, that is a normal. And you also have the 0.4%, 4-5% normal saline. That is half normal saline is also available. It may lead to hyperchloremic acidosis. So, this may aggravate or be confused with the lactic acidosis from prolonged shock. When serum chloride level increased the normal range, so it is advisable to change to the Ringer's lactate. Okay. Approach to a patient of severe dengue and compensated shock. So, stabilize ABZ and fluid resuscitation. Again, here, when you are giving the fluids in the shock syndrome, you have to go in a step down approach rather than the step up approach in the dengue shock syndromes. In dengue shock syndrome, initially you have to give 7 ml to 10 ml per kg body weight per hour. So, for example, the fellow is about 80 kgs. Okay. So, straight away can give for the half liter, 500 ml per hour. So, 7 to 10 ml per kg per hour. And then in the first 1 hour or 2 hours, and then you check the vitals, then you can come down to 5 ml per hour, per kg per hour. And then maybe the 3 ml per kg per hour, maybe the 2 ml per kg per hour. So, in dengue shock syndrome, you approach the method of step down approach rather than the step up approach. So, give more fluids in the initial 1 to 2 hours and then check the vitals and see whether the fellow is having the good output, etc. And then you come down. And another important point to be noted for your step down approach, your HCT, your packet cell value. So, in the initial, the packet cell value is very high. So, you give more and more IV fluids, and later the PCV, packet cell volume or HCT, will come to the normal values. Then you have to reduce the IV fluid therapy according to your HCT. Okay. So, this is your step down approach. See the fluid resuscitation with 10 to 20 ml per kg of the isotonic crystalloid or colloid over the 15 minutes. So, for example, if the patient is about 60 kgs, then you have to give about 600 ml to 600 ml. That means almost one half liter you have to administer in about 15 minutes only, 20 minutes only. So, that much speed you should maintain in the dengue hemorrhagic fever or the dengue septic shock. And correct the hypoglycemia and also hypocalcemia. Observe for the improvement. Maintain the crystalloid or the colloid here at about 1 to 3 ml per kg per hour. So, after reaching your HCT, so you can come down, your step down to about 1 to 3 ml only. Suppose if the patient is 60 ml, 60 kgs or 70 kgs, just 60 ml or 70 ml per hour. So, that is our maintenance dose. So, monitor the HCT 6th hourly. Check for the recurrence of the clinical instability and review the HCT. HCT increases, again you can increase the IV fluids. HCT decreases, so you can stop also. Review the baseline HCT high, give the second bolus of the crystalloid. If the HCT is very low, you have to go for the signs of the bleeding tendencies. So then go for the whole blood or the packet cells transfusion. See the unrecognized morbidities that may contribute to the refractory shock. So in spite of that, you started with the crystalloids like normal saline, then you have checked the HCT, and then you started with about 8 ml or the 10 ml per kg body weight, and then you step down and you are assessing according to your HCT, and the HCT is very low. You are advising your packet cells, blood transfusion, etc. But still, the patient is in the shock. That is a refractory shock. In spite of your crystalloids, in spite of your colloids, in spite of your blood transfusions or RBC transfusions, etc. So what to do? So occult blood, clinical condition, occult blood. So then whole blood or the RBC transfusion. Or coexisting bacterial septic shock or the malaria. This is the very important in our places. So the dengue sometimes associated with the septic shock, other bacterial infection, associated bacterial infection or associated malarial infection. Then you have to give the appropriate antibiotics and also the antimalarials plus blood transfusions plus cardiovascular support. So to reduce that shock. Myocardial dysfunction. Okay, your cardiovascular support. Elevated intra-abdominal pressure. So drainage. Positive pressure ventilation. So titrated fluid and cardiovascular support. Widespread hypoxic ischemic injury with a terminal vasoplasic shock. So the no treatment effect. So they are all seen by your intentivists usually. Okay. So still in the refractory shock. So these points has to be assessed. So whether the fellow is having a coexistent bacterial infection or coexistent malaria or any myocardial dysfunctions or any abdominal pressures, etc. Treatment of hemorrhagic complications. Give 5 to 10 ml per kg of the fresh packed red cells or 10 to 20 ml per kg of the fresh whole blood at an appropriate rate and observe the clinical response. Fresh frozen plasma, about 600 ml, may contribute to a significant increase in the platelet count in the first 12 hours. So mostly the single donor platelets. Consider repeating the blood transfusion if there is further blood loss or no appropriate rise in the hematocrit after the blood transfusion. Always see the HCT or your packet cell value. So that clinches you whether to give the further blood transfusions or you have to stop giving the further blood transfusions. Suppose still the HCT is very, very low, you have to give the further blood transfusions. And factor 8A, effect in restoring the hemostasis in a limited series of the patients with the dengue shock syndrome exhibiting the life-threatening bleeding episodes. Congestive phase, change over to the hypotonic fluid, decrease the infusion rate to 3 to 5 ml, maybe 1 to 2 ml also. Diuretics, digitalization needed in patients with the cardiac overload due to the regurgitant fluid. So usually we give the diuretics, we don't digitalize the people here unless the patient is a known cardiac case or a known case of a rheumatic heart disease. Otherwise, don't give the distillate. Give the diuretics. Another important do's and don'ts. Don't use steroids. That is the most important thing. So in India, in any fever, most of the RMPs, they use the steroids. So don't give steroids. They are not indicated and can increase the risk of the GI bleed, hyperglycemia, and immunosuppression. Don't give platelet transfusions for a low platelet count. Platelet transfusions do not decrease the risk of severe bleeding and may instead lead to the fluid overload and prolonged hospitalization. So more fluid overload, more hospitalization because of the platelet transfusion. So they don't decrease the risk of bleeding. Don't give off normal saline. Off normal saline should not be given even as a maintenance fluid because it leaks into the third space and may lead to the worsening of the ascites and the pleural effusion. So there is the third don't. First don't is steroids. Second one is platelet transfusions. Third one is off normal saline. And the fourth don't is don't assume that IV fluids are necessary. Okay. First check if the patient can take the fluids orally. Use only the minimum amount of the IV fluid to keep the patient well perfused. So don't depend on the IV fluids always. Okay. Decrease IV fluid rate as hemodynamic status improves or the urine output increases. What are all the do's? Do tell outpatients when to return of these warning signs. When there is a probable dengue, so you are giving the OP based treatment and tell the patients about the warning signs and then ask them to come back once they have these warning signs. So teach them about the warning signs and their timing and the critical period that follows the. Do recognize the critical period. As a good physician, you should recognize the critical period. The critical period begins with the deferescence and lasts for 24 to 48 hours. During this period, some patients may rapidly deteriorate. Some people, they may rapidly deteriorate at this juncture. Do closely monitor fluid intake and output, vital signs, and hematocrit levels. Ins and outs should be measured at least every shift and vitals at least every 4 hours. Hematocrit should be measured every 6 to 12 hours at the minimum during the critical period. During the critical period, it is very important to check the HCT at least twice or thrice a day. Do recognize and treat early shock. Early shock, also known as compensated or normotensive shock, is characterized by narrowing the pulse pressure, increasing the heart rate, and delayed the capillary refill or cool extremities. Okay, the sister says the BP is normal, 120/8, 120/8. So don't think that 120/8 is the normal there. So these are the early shock. So what are the symptoms of what are the signs of the early shock? The BP is the normal, but there is a narrowed pulse pressure. So unless you check the blood pressure, the sister won't give much importance to the diastolic blood pressure. She gives importance to the systolic blood pressure, and then diastolic they say always 80. When the systolic is 120, she always says the diastolic is 80 only. But if you check the diastolic, that is about 100. So that means narrowed pulse pressure. So that is the most important early sign of the shock. So not only that, narrow pulse pressure, see the heart rate. When the heart rate is more than 90 or the 100, tachycardia, again a feature of early shock. And then the delayed capillary refillings. If it is more than the 2 seconds, so again a feature of early shock. And then cool extremities. So palpate the peripheries. So again cool. So these are all the features of the early shock, even though the blood pressure is normal. So you have to check the pulse pressure, you have to see the heart rate, you have to see the cool extremities, and then you have to see the capillary refilling pressure time. Do you administer the colloids such as the albumin for the refractory shock? Always give the colloids like albumin for the refractory shock. Patients who do not respond to 2 to 3 boluses of the isotonic saline should be given colloids instead of the more saline. Okay. Give RBC or whole blood for clinically significant bleeding. If the hematocrit is dropping with unstable vital signs or the significant bleeding is apparent, immediately transfuse the blood. So I think this is the best slide of our today's talk. Okay. So don'ts, 4 things. What are they? Steroids, platelets, off normal saline, and IV fluids in all the cases. Okay. What are the do's? Tell the warning signs of the dengue for all the OP based dengue patients, and then recognize the critical period. Okay. Closely monitor the fluid intake and output, vital signs, and hematocrit levels. Hematocrit levels at least twice or thrice a day. And then recognize the early shock, even though the blood pressure is the normal. Okay. And then administer the colloids such as the albumin for the refractory shock. And then give the RBCs or the whole blood transfusions when the hematocrit is falling very rapidly. So these are the do's and don'ts of the dengue management. The same thing. Avoid IM injections again. Okay. So don't give the IM injections in the dengue fever. Okay. So there will be chances of much hematomas there. Administer the paracetamol for the high fever. Now the ibuprofen IV is also available. Diclofenac IV is also available. Okay. Or ketorolac IV is available. So don't give such things, only paracetamol. Use isotonic IV fluids for the severe dengue. Give intravenous fluid volume just sufficient to maintain the effective circulation during the period of the plasma leakage for the severe dengue. If you give the more and more fluids, the people will go into the pulmonary edema. Tight glycemic control provided if the patient is a diabetic. So maintain the blood sugar between 140 to 180. Okay, or even 110 to 140. So don't aim for the hyperglycemia more than the 180, or don't aim for the hypoglycemia less than the 110 in the admitted patients. Don't administer aspirin or the brufen. Use hypotonic IV fluids for the severe dengue. Excessive or prolonged IV fluid during the severe dengue. Insertion of the following carries the risk of the hemorrhage. So this is a very, very important in the severe dengue population. Nasogastric tube. So while putting the nasogastric tube or orogastric tube, there are chances of bleed inside the bleed. Okay. Intercostal drainage. Judicious use of the IV fluids and the furosemide. Central venous line. So intraosseous route is the preferable. So by some people though they need the nasogastric tube, central lines, etc. So be careful. Otherwise, there is a risk of hemorrhage. Steroids are of no benefit. Efficacy of heparin not documented here. If stable with the fluid resuscitation, consider it the minor mucosal bleed. Profound thrombocytopenia, strict bed rest and the protection from the trauma. Don't give IM injections. Watch out for the black stools, that is the melena. So the hemorrhage is from the stomach and the duodenum. So what about the complications in the dengue? So left untreated. So severe dehydration, severe bleed, severe hyper or hypoglycemia, bradyarrhythmias or cardiac involvement, electrolyte imbalances, acid-base imbalances, or metabolic encephalopathies, and co-infections like respiratory tract infections or IV fluids, IV site infections, etc. And hypervolemia, that is the most frequent cause of the death. So this is the most iatrogenic death. Okay. So don't give 5 or 6 or 7 pints a day. Okay. Hypervolemia, this is a very, very common. Death in dengue, most common is the hypervolemia and the early clinical features of the fluid overload. Respiratory distress, difficulty in breathing, rapid breathing, chest wall indrawing, wheeze rather than the crypts, large pleural effusions, tense ascites, and raised JVP. Okay, so these are the features of the fluid overload. So raised JVP you can see ascites, large pleural effusions, wheeze, chest wall indrawing, tachypnea, okay, respiratory distress, difficulty in breathing. So these are the features of the fluid overload. And the late clinical features, pulmonary edema and heart failure. So what about the discharge criteria? So you know that, okay, so when to discharge the fellow. Clinical, no fever for the last 2 days. Improvement in the clinical status, like general well-being, good appetite, hemodynamically stable, good urine output, and no respiratory distress. So these are very important. So you have to see all these things. So before you discharge the fellow. Laboratory, so there will be increase in your total count, increase in your platelet count, and also your HCT is the stabilized. These are all the signs of the recovery, good urine output, etc. Prognosis, poor prognostic indicators, early and profound shock with no detectable diastolic pressure or unrecordable BP. Even today, we see in the casualty with these patients. Okay, the early and profound shock, the fever of 10 days, fever of 15 days. So use a lot of the steroids. So okay, so comes to emergency department with no BP, not recordable, etc. Delayed admission to the hospital. Shock syndromes with the gastrointestinal hemorrhage. Causes of death, failing to recognize that a patient is in the shock. So I told you, early shock features. If you don't recognize that shock, and after 3 hours or 4 hours, this fellow will be in profound shock. Hemorrhages, failing to recognize the patient has entered the congestive phase. So you fail to enter that, recognize that the patient is in the congestive phase and ask the sister to give more and more fluids. So you are inviting pulmonary edema. So now how to prevent the dengue? Last few slides. There is no vaccine, but sometimes the WHO has given one vaccine is available, but I don't think that it is available in our place. Best preventive measure is eliminate the mosquito breeding points. So there are all the breeding points here. Okay. Change the water in the flower vases on alternate days. Remove the water from the flower pot plates on the alternate day. Sanitation is important. Vector control is important. Dengue vaccine. Remove all sources of the stagnant water. Deny the Aedes mosquito of any chance to breed. Change water in the vases and bowls every other day. Add sand granular insecticide to the water. Remove water from the flower pot. This is a very important. Okay. Turn over all storage containers. Inform your parents or any adults in your household to clear blockages and put insecticides in the roof gutters at least once in a month. If you are going on a holiday, seal off all floor and gully traps. Cover all toilet bowls. So wear shoes, socks, long pants and long sleeve shirts. Use mosquito repellents, mosquito coils, mosquito nets. So use all these things when you are going to see the Kalki movie. Okay, last half an hour it's very difficult. Lot of goosebumps. Conclusions. Dengue is one of the world's most important emerging disease. Already emerged. So we are seeing both sides of the coin in the dengue. Rising global incidence and explosive epidemics is a major challenge. So further advances. So further understanding the immunopathogenesis, pathophysiology, identification of better therapeutic agents, improved diagnostics, so early detection to guide the evidence-based practice, predict the epidemics much early, develop an effective and the balanced and functional vaccine for all the serotypes, address the public about the disease as a global threat. So thank you very much. Beware of the bite, mosquito bite. So thank you very much for your patient hearing.